You're listening to a speech therapy PD podcast. Earn 0.1 ASHA CEUs for this episode by completing the accompanying course online at speechtherapypd.com.
Okay, folks, well, welcome back to First Bite. I'm Michelle Dawson, the host, because apparently I'm supposed to be saying that at the start of podcast, and I'm definitely a speech therapist first and a podcaster second. And I am, like, if you looked at my little watch, my heart rate is elevated because I am in such a fangirl moment because we have Dr. Britt Pados, and y'all, like, she's basically published all of the things that I have encouraged everybody to use as resources. So like when Dr. Goza and Dr. Dean Marshall came on years ago and they were talking about proms and why we use these tools, it's Dr. Pados's tools that they were like describing to every graduate student I've ever given the assignment to go look at the PD Eats or look at all of these resources or nipple flow rates. It's her. So, hi, I have none other than, and you get a none other than, Dr. Britt Pados, who's a neonatal nurse practitioner and international board certified lactation consultant, a certified trauma-informed professional, and a fellow of the American Heart Association. And y'all, she is actually recording in her office with where she sees the tiny humans. And I love that you have given us this foundation, but yet you still practice clinically. That makes
That's the best part of my day is the little people, right?
Yes.
And it reminds me all the time of like why all of the other stuff is so important.
Yes.
Yeah.
Okay. General curiosity. Do you have a running tab of how many times you've been thrown up on?
Oh God. No, but you know, whenever I think about like, why do I wear scrubs? That is why, like the throw up, the poop, all of the things, or just like leaking bottle, you know, I mean, yeah. It's why I don't wear real clothes.
Yes. My father-in-law made the joke and he goes, "Do you own pants?" And I'm like running around in my little leggings and I'm like, "I have on pants." He goes, "Those are not pants." And I was like, "Look, I used to wear scrubs, but they're a negative sensory experience for me. I'll acknowledge." So I like my stretchy pants with like my multiple layers. So that way, if, you know, pee, vomit, emesis happens, I can strip a layer and toss something else on. But yep. I do own a pair of pants and they're my fancy jeans. So Mr. Dawson knows I'm dolling up if I put on my fancy jeans. Plus, thank you so much for coming on. If you're a graduate student listening to this, you'll know you've made it when you too have been peed, pooed, or thrown up on. Sure, rite of passage. But
well, thank you for having me.
Thank you. I have wanted to know for years, how did you decide to go from nursing to bottles and nipples to GI? Because I have two sisters that are nurses, one stepsister and one sister-in-law. One's a GI nurse, one's a cardiac ICU nurse. But like, I can't fathom them ever going that route. And it seems so passionate. Like, what drove this?
Yeah. So, I mean, I have like always loved babies, like been fascinated by babies since I was like a little tiny person, you know? And my grandma was a nurse. And she would always she was a pediatric nurse. And so she would share stories, you know, with me. And I just like was always fascinated. And, you know, I think, going into college, I decided, you know, to go the nursing route. I thought actually about physical therapy too. I had a pretty significant knee injury, playing soccer in high school and spent a lot of time in PT. And so it was kind of like between PT and nursing, but decided to go the nursing route. And, you know, going through kind of the clinical experiences, I had the opportunity as a senior to do a clinical experience in the NICU. And, I had done labor and delivery before that, and I loved labor and delivery, but I always was like, okay, the baby's out. I want to go with the baby. And, loved the Well Baby Nursery, and then found the NICU and was like, this place is amazing. Yeah. And so I sort of broke the rules in that they kind of tell you, like, don't go straight into the NICU out of nursing school. And I was like, there is nowhere else I want to be. And so went straight into the NICU, and it was hard. I mean, don't get me wrong. That was a very hard place to start. But the other thing I had done in my kind of undergrad program was a research kind of fellowship. And so I had been kind of working with one of my professors who was a researcher, and she did like Alzheimer's research. So it was a totally different topic, but I was just really, intrigued by research. And I think when I got into the NICU, I realized we have so little research to support the work that we're doing, really, compared to a lot of other areas of medicine, like the NICU is relatively new, and our ability to save these really tiny babies is relatively new. And so, I realized pretty quickly that that was an area that just needed more research. And so I pretty quickly moved from kind of being a nurse to going back to school to get my master's, to become a nurse practitioner, and went and worked in New York City at a level 4 NICU as a nurse practitioner, which was a crazy experience, but a really awesome experience. And what was really special about that hospital was that they had, so a lot of children's hospitals, when a baby needs cardiac surgery, they go to a cardiac ICU. So they might like start in the NICU, but once they have surgery, they go to the cardiac ICU and or PICU. But at this hospital, those babies came back to the NICU with us. And so we had kind of a NICU cardiac team. And so I was one of the nurse practitioners on that NICU cardiac team. And one of the things that I really started to notice was that these babies would survive these really life-threatening, complex surgeries. And we would kind of, like, the families and the healthcare team would sort of all think that, like, we were kind of past the hardest part. And then we would start to feed them, and they had so much trouble, and it would take weeks and weeks, sometimes, months, or we would send them home with a tube, or they would go home and then come back for subsequent surgery, really malnourished and, not in a sort of physical place where they were kind of in an ideal place for surviving a second surgery. And I just really started to kind of notice that as an area where, at the time there was quite a bit of research going on in the world in the NICU around premature babies and feeding. And there really wasn't a lot around feeding babies with congenital heart disease.
Yep.
And, that idea of like, so there was sort of this historical thought around feeding premature babies that they got tired quickly and they just weren't as strong as full-term babies. And so like the historical idea was, well, let's make feeding easier for them by making flow faster. So that they don't have to sort of work as hard at it, right?
Yep.
But then over time, as more research was done, we started to learn that actually one of the things that makes them become fatigued during feeding is that they're not breathing enough. And that when flow is really fast, every time they swallow, they have to hold their breath. And so when flow is fast and they have to swallow, hold their breath, one of the things that makes them tired is that they're not breathing enough. And so, we started sort of moving towards actually, slowing down the flow actually allows them to breathe more. They maintain physiologic stability better. They are able to not become as fatigued and sustain a little bit more during feeding. So some of that work was kind of happening around the same time. And so I went on to sort of get my PhD, wanting to explore kind of this idea in babies with congenital heart disease of, should actually we be using these slower flow nipples? Like, would that help those babies too? And so I sort of started my PhD program with this kind of question in mind of like, how do babies with congenital heart disease respond to different flow rates? And as I started kind of planning that study, I had to really think about like, okay, well, if I want to do sort of feed some babies with slow flow nipples and other babies with standard flow nipples, there's a million nipples out there. And
but there are, and there's even more now.
And there's like 3 times as, you're right. I know there's like new products every single day. But there was sort of this question of like, okay, well, so these 5 brands all call their product slow. Like, are all of those the same? Like, what does slow mean? And then it was like, well, if I was going to pick something that was like standard flow, what is standard? Like, who came up with that? How much faster is standard than slow? Mm-hmm. And so I really had to like dig in to look at these nipple flow rates to figure out like, okay, well, if I do this study in cardiac babies, like what nipples am I going to use? And that is how kind of the flow rate testing came about. And it has now taken on a whole other life of its own that I would have never imagined. And so that's kind of how all the flow rate testing started. And then I think as I got into it, I realized, wow, as a nurse, when I was feeding babies, if a baby fed well at one feeding and didn't feed well at the next feeding, I thought that had to do with the baby. Mm-hmm. But then as I started doing this flow testing and realizing that there was so much variability in some of these products that we were using, and so even if I was using a disposable nipple, and even if I was using the same kind of nipple at one feeding, and then I threw that one away and I got the same kind of nipple, but a different nipple, that those flow rates could have been wildly different.
Yes.
And maybe it actually had something to do with how babies were feeding.
Yes.
Right?
So out here in like the home health early intervention world, your research has been so helpful because when we go into homes, a lot of the environments, so background, I cut my teeth professionally in Gloucester, Virginia, then spent 12 years practicing in Columbia, South Carolina, but predominantly in the city and out in the country. But I got called in for like complex cases, right? Yeah. NICU discharges from MUSC, NICU discharges from Prisma. It was Palmetto Health and then Prisma. And then moved to Virginia, and here I am again out in the country. And what we see is caregivers will say, well, this is the bottle that we're using. And the benefits of being in home health. Okay, show me your cabinet. Where do you keep them? And then they open this cabinet of doom and like everything falls out, right? Which gives me anxiety.
Tried literally everything. Yep.
Yes. You should see my Tupperware cabinet. Bear's not allowed to put the Tupperware away because it makes me twitchy because I see that all day long. But what we hear is, okay, well, this one worked for a while and then it stopped working. Or we tried this one and then it didn't work. But we can say, hey, well, those nipples break down over time, or the heat, the pressure, the pulling, the biting, the tugging. All of those variables. If Big Brother uses it, because sometimes they share the same bottles, but Big Brother might be two still using a bottle, not touching that with the 10-foot pole in today's episode. But if they're chewing on it, that's going, or they pull out their pocket knife. And I've literally seen daddies pop a nipple and they're like, well, it comes out easier if I just cut it real quick. And you're like, oh, also, was that sanitized? Probably not. Who know what you use that pocket knife for? That's the real world.
Yeah.
But y'all, I will link, she shared notes, so I'll make sure that her resources get tagged into the show notes. But you can use this to find a bottle nipple that will support the socioeconomic status of those that you work with. But also, oh, by the way, Dr. Brown's will also ship for free to your clinics. And oh, by the way, Dysphagia Outreach Projects gets donations and you can connect caregivers there. So if over today's episode, you're like, hey, this is great information, my families can't afford this.
Yeah.
There's community resources that you can access to help. So I just, as Mr. Rogers says, find the helpers. So those are our helpers, and just going to move on.
There's also, if, so on infant feeding labs, there's a form that you can tell me which products you want me to test. So if there's like products that your families are using, make sure you let me know so that I can add them to my testing list.
Okay, I grew up on a farm and we raised beef cattle, but one time my pop decided to get a dairy cow and I thought my grandma was going to skin him. But I remember like having to milk the dairy cow. So please know that the first time I came upon your research, I imagined y'all doing this with the bottle nipples. And I was like, no, Michelle, I guarantee it was not like that. But that was my frame of reference because I read it pre-children.
Yeah. And then, yeah.
Sorry. Yes, people, that's how my ADHD neurodivergent brain goes. But on that note, hi. So do you have, did you have like an aha moment in one of your studies where you were just like, this is terrifying information or this is brilliant information? Was there ever like a
Yeah, I mean, pretty early on in the flow rate testing, I started to realize like this is really important information. Just seeing kind of the wide range in flow rates of like even say within the category of slow, that it could be so wildly different that it was like, this is really critical information because that decision of like which product we choose is going to have a major impact on how babies feed. So yeah, I would say that became clear pretty early on. And I think because of that, typically like it takes years and years and years for research to actually change practice. But I think because this was like so clear,
yes,
that it mattered. And I think it validated what so many people who were actually feeding babies were already seeing.
Yes.
That I think one of the like most fun things for me has been seeing how quickly people have adopted this into their practice, that like, that it hasn't been something that has taken, I mean, certainly it's taken years for lots and lots of people to become aware of it. But it really has changed practice faster than a lot of research does.
Yes. Folks, what she's referencing is that what is the average? A 12 to 20 year pipeline is the average research to practice. It's something horrible. But this has happened like wildfire, but in a good way. So yeah. Okay. So one thing that we mentioned before we came on was talking about the GI component. And I shared that I have struggled clinically with, for lack of a better phrase, gatekeeping. right? Gatekeeping for interprofessional practice. I would go in, do a clinical swallow eval, and see signs and symptoms of, hey, this is beyond my scope of practice. We need an extra set of eyes and ears. Especially, we've had Dr. Richard Noel on the podcast previously. Like, we've had GI practitioners come on or pediatricians come on and talk about the need to get to GI. Have you heard bowel sounds? Okay, bowel sounds is by NASAFGAN, the North American Society for Pediatric Gastroenterology. I might have dropped an H. They have their own podcast called Bowel Sounds, but the cover looks like the large intestines connecting to headphones. It's the cutest thing in the world. Awesome. It's great. But they get researchers and practicing pediatric GI on to talk about it. So I've listened to enough of those that I'm like, well, this is great information, but now I'm horrified when I go do an eval and I'm like, we really have to get into pediatric GI. And lo and behold, you have research to talk about this. So guide us, make us better.
Yeah. That really, so in my PhD program, so I did like the study on feeding babies with congenital heart disease, different flows, blah, blah, blah. And then started looking at sort of this, I started getting interested in this period of time kind of after NICU discharge.
Yeah.
Because there was really, like, at the time, very little outcome information in, say, the first year after NICU discharge. So we had some kind of like studies based in kind of feeding clinics of older children showing a lot of those kids actually were born premature and spent time in the NICU. But there was kind of this like gap of information of what was happening for babies in that kind of first year. And so started doing some research looking into kind of outcomes after NICU discharge. And that's where some of the need for these assessment tools came into play, and sort of where we started realizing, well, if we're going to look at outcomes, we really need a way to measure these things. And that's kind of why the assessment tools were developed. But in doing all of that, as I started doing more and more research, every single time GI was coming up as a factor. Like, reflux was coming up. It became so clear to me that we cannot talk about feeding without talking about
the GI system.
GI system. Right?
Or the airway. Pick your struggle. Or allergy. Those are your big three.
Absolutely. Right? And yeah, and so it just became so clear in study after study after study was just like high correlation. When we look at problematic feeding outcomes, GI and reflux were always part of the picture.
Yeah.
And we still need lots and lots of research in this area to understand this better. And, around the same time, the pediatric feeding disorder consensus statement came out and did include kind of that medical piece of it. And GI kind of falls under that. And then now in my own clinical practice,
folks, if you're listening to this and not watching our faces, it's just like, what the hell is going on, people? Like, that's the look. So continue.
And I guess sort of like my current thought process is babies are not going to eat if they are uncomfortable.
Correct.
Right?
They listen to their body. That's their communication.
Absolutely. So they're not going to eat if they're unsafe from a swallowing airway perspective. And they're not going to eat if their eating causes them pain. They are far smarter than we give them credit for. And they learn pretty quickly that if every time I eat, my belly hurts or I have terrible reflux,
they stop
they don't
eating.
want to eat. Absolutely. And so we can do all of these, we can change flow, we can change position, we can do all of these other things. But if they have a cow's milk protein allergy, if they have terrible reflux that we're not managing, if they're constipated, none of the other things that we do are going to make any difference. Like, we have to fix those other things first.
Yes.
Yeah.
Yes. And typically in the world of early intervention, it's the SLP that goes in that gets the consult first. Or I know in my immediate area, it was an OT that I work with. Like, she got called in because there was no SLP. And that's your frontline defense. But that's on us knowing the signs and symptoms of what we're looking for.
Right.
And I put that back on our graduate programs because unfortunately, most graduate programs do not have a standalone pediatric feeding and swallowing class. Yeah. It's embedded within the dysphagia class, which is historically taught by an adult dysphagia researcher. So I put the onus on all of those that are faculty, myself included in that hat when I teach adjunct. Like, we have to make sure that we're teaching potential signs and symptoms so that we're clearly outlining the 4 domains of pediatric feeding disorder and then correlating, okay, these are the subsets under medical. This is, yes. But you have, and I'm going to pull it up. It's called, and this is free open access. Also, thank you for making so many free open access publications. Like, thank you. The gastrointestinal and gastroesophageal reflux GIGER scale for infants and toddlers. This was first published July 14th, 2021. And you can find it on Sage, but can you talk about what GIGER? When I read GIGER, I'm thinking of MacGyver. I don't know why all of a sudden I see like the world getting rescued with like paper clips and like a hot glue gun. But
that is what our job feels like sometimes.
Oh my God, especially today. I can take no more news, but yes.
Yeah.
But can you talk us through what is the GIGER and how can we use that?
Yeah, so it is a parent-reported outcome measure.
For those, yep.
Right. And that just means that it is the parent filling it out. It doesn't require any special training or anything like that. It's really just answering questions about their child's behavior related to their gastrointestinal or gastroesophageal reflux symptoms. And so it's available for free on infant feeding care. I think we'll probably link to that. And so it's something that either healthcare providers can download or parents can even download, fill it out. There are reference values you sort of come up with a score and then you compare it to reference values for the child's age to determine whether those symptoms kind of fall within the range of normal or if they're outside of the range of normal for that child's age. And it's super important if a baby was born preterm, to use their corrected age for determining the reference values. And so the way that people can use that is, if you are like as an SLP or a PT or an OT, you're not in a position to be able to manage those GI symptoms or make a diagnosis or, make recommendations about sort of other strategies related to those symptoms. But, this is where if you're working with a pediatrician or working with GI, that, having an objective measure and then having a score and being able to show that this is outside of the range of normal for this child's age, that can go a long way in helping to sort of build the case that this is a baby who would really benefit from having these symptoms managed. And that then by managing those symptoms, like your job as an SLP, PT, OT, that you can really make a lot more progress once those symptoms are managed.
Okay, so folks, I'm going to tie in a couple of thoughts. It is within the SLP scope of practice to make a referral request. We cannot make the referral. That is outside of our scope of practice. But, and I'm very cautious about this, ASHA right now is updating the SLP scope of practice because this gets tweaks to morph, and it's typically not like a significant overhaul, but like small edits are being made. So as of today, and we are recording in advance, so it's January 23rd. I don't know when it will be closed, but this morning, because yes, I do check a litany of news when I first wake up. They announced on the ASHA communities that they just opened up the SLP scope of practice for feedback from membership. I didn't catch the close date, but if you feel strongly that we need to continue to keep that aspect within our scope of practice, or expand, and I don't know if you have any other suggestions, please go fill out the feedback section. I feel very strongly that that is one aspect of our job that we need to continue focusing on, because I need to be able to say, hey, I just did a speech eval on this tiny human, and I'm concerned they're not hearing because we have a past medical history of 8 ear infections or, you know, whatnot. But please, 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 you are ASHA, go advocate. But also, I feel like that's a tool that's like, well normed, the GIGER, talking about the GIGER, like this is a resource that I can do with my families there in a session when it's caregiver coaching, so that they can answer any questions if they're not familiar with terminology, or if I need an interpreter present, and then they can take that back to their provider, which creates an opportunity for a conversation.
Yeah. And it helps facilitate that conversation in a way that's more productive. So, you know, if a parent goes in and says, like, my baby's having like lots of discomfort, they cry all the time, that is a little bit harder for a pediatrician in a very short amount of time to try and kind of pull out, okay, what's going on. Whereas if you know, on the GIGER, it helps sort of say, these are the specific things that I'm seeing that I'm worried about. And it just helps facilitate that conversation to make it more productive.
That's awesome. I'm going to print this because so at work we round on Thursday afternoons, and it's like my absolute favorite thing. I love rounding on the tiny humans. But this came up literally yesterday afternoon. One of the PTs was like, hey, she got called in to work with a little one, but we're now a year old, and it's the acid reflux that's just kicking in. And she was like, he's spitting up everything, and he's so much smaller. And I'm like, all right, cool. But this is something that I can give to our PT or, you know, anybody on the team and be like, hey, additional resource.
Yeah. Absolutely.
So how do, like clinically, when they come to see you, how do you filter all of this advanced knowledge to help during a clinical swallow eval? Can you like walk us through what a case looks like? Because I feel like that would bring it home in full picture.
Yeah. So I do have my patients fill out, unless they're like brand new, because I do lactation support also. So I see some babies that are like, you know, a day old. But I know it's so fun. For the like slightly older babies, I do have the parent fill out the infant eat ahead of time, and so that's like a 30-ish question parent report outcome measure. And that really helps me start to identify, and like I have them give me a short history But from that, I can start to sort of tease out and start to think about, okay, do I think this is a swallowing issue? Do I think this is a GI issue that's impacting feeding? I can start to sort of identify some questions within the infant eat, and I'll actually like write them down for myself to then follow up during the eval to dig in a little bit deeper to say like, okay, you said that your baby, you said in the questions that you filled out for me that that they sound gurgly when they're eating or after they're eating. Like, tell me more about that. Mm-hmm. Or you said they cough sometimes. Like, tell me more about when that's happening. And so doing that ahead of time, one, it sort of gets me thinking about like, what else do I want to dig into deeper when I'm doing the evaluation? Like, what do I want to be? And of course, you're sort of always looking at everything, but it helps you sort of be like, I want to really look closely at their swallowing, or really dig deeper into sort of like what is happening outside of feeding, like what is their behavior like, to sort of start thinking about like, is this a swallowing issue? Is this a reflux issue? Is this a kind of lower GI issue, constipation? Is there the potential for an allergy going on, cow's milk protein allergy? Is that kind of what you're...
Yeah. So when you say cow's milk protein allergy, I have always processed that as bright green, pink, or red in the stool. What other symptoms should we be looking for?
Yeah, so I think this is something that we just need way more information about.
Also, with the change in the dietary recommendations, I have so many children that can't process dairy, and it terrifies me, if I'm just being honest. So, yes.
Yeah. So first of all, there's two types of allergies. So when we think about allergy, we often think about kind of that anaphylactic reaction, right? Like
lip swelling, can't breathe,
hives, EpiPens, that kind of thing. So that is sort of, the most dangerous type of allergy, right? But it's also possible to have an allergic reaction that only involves the gastrointestinal tract. So that's sort of like what we called food protein.
FPIES, food protein induced enterocolitis.
So that's kind of typically in slightly older babies. Often when we start solid foods is when like FPIES comes into play. And then there's food protein induced allergic proctocolitis, which is involving the intestinal tract and leads to sort of changes in stooling or potentially mucus and blood in the stool.
And it looks gross.
So, it's interesting. It can there's just a wide spectrum of what that can present as. So I've had babies that present, certainly it's easy to sort of become alarmed when there's red blood in the stool, right? Then everyone is like, it's very clear there's a problem. I think where it's more difficult are those sort of more subtle cases. So you can certainly have blood in the stool that's not visible, that can only be identified by actually testing the stool for blood. You can have mucus in the stool, which looks kind of like, almost like snot. It's like a little bit stretchy, or just kind of like clumpy in the stool. You can have, like you said, sort of like bright green or sort of like dark green. Very watery stool can be kind of a presentation. Or I've had babies that present with constipation, where it's like, absolutely. I had a baby come in, mom was breastfeeding, and the baby pooped once every 10 to 14 days.
Oh my gosh.
And she came in because she was concerned about a tongue tie. And I was like, okay, let's back up a little bit.
Yeah.
And she said, well, my pediatrician said that since we're breastfeeding, some breast milk fed babies only poop every 10 to 14 days. And I, first of all, I don't know where that information is coming from.
Correct.
But it's certainly something that people say. And I will often sort of respond to that by saying, if a baby is eating well and growing well, and they're only pooping every couple of days or maybe once a week, but they're comfortable, they're happy, they're eating, they're growing, then okay, maybe that's not a problem.
Yeah.
If this is a baby that's not pooping regularly, meaning at least once a day, and they're not feeding well, they're not growing well, or they're uncomfortable, then it's not okay.
Mm-hmm.
And so in that particular baby, we had mom take cow's milk out of her diet. And I generally also recommend taking soy out of the diet because there's a lot of cross-reactivity. So babies that respond to cow's milk protein often respond to soy as well. And within a couple of days, the baby started stooling regularly.
That's amazing.
It was a profound change. Yeah, and so there can really be a wide kind of variation in presentations of kind of what cow's milk protein allergy looks like. It can also look like a baby who is stooling okay and eating okay, but not growing. I've had some babies present that way where they seem like they're eating enough, but they're just not absorbing it well.
As we say, is it something like the protein is inhibiting the body to absorb for caloric metabolic needs?
Right. So, as that their intestines are responding to that food protein with this sort of abnormal way, that produces inflammation along the GI tract, and then they don't absorb as well.
Yeah. Have you ever read Gut?
No, I think I have it on my list of things that I want to read though.
It's really good. Folks, I'll sync that up, but she does talk about some really cool stuff, even different bacterias. She went down the rabbit hole of H. pylori, how they're even they can even trace our ancestors and our lineage by which H. pylori infection an individual has, which is crazy because the Pacific Islands have a different H. pylori bacteria versus a European-based H. pylori bacteria. Huh? Right? I was like, that's a cool rabbit hole.
Yeah. There's so much we don't understand or don't know yet.
Yeah. Yeah.
Particularly in kids.
Yes. Okay. So one thought when you were talking about the red in the stool, and this is something that as I didn't get until I got as a mom, my oldest had chronic infections and he got put on Ceftonir. And there's a warning label on Ceftonir that says may turn stool red. Okay. Did I read the warning label? No. Did I panic thinking he had hemorrhagic gastroenteritis? Obviously, because anxiety, I go deep, dark, scary places first. Called the pediatrician who, Bartlett, bless her heart, got on the phone with me. She's like, Michelle, it's Ceftonir. He's not bleeding internally. We're okay. But it's really important. I was sleep deprived, exhausted. That's what happens when you're a first time mommy.
Yeah. Same when you feed them beets for the first time. And then you kind of forget that you fed them beets and then
or prunes because I was like, I'm going to be a great mom and introduce one food a day for 2 days and then see how we do. And I fed Goose prunes for 2 days. and that didn't understand why he was pooing everywhere, because I could be a mom or I can be an SLP. So he survived. He's 13. But I say this because when she's talking about all these signs and symptoms in stools, we have to know as practitioners to remember to ask, what medications are they taking? And be aware. And that's not really in our wheelhouse, right? And so which is again why we're not supposed to act as silo practitioners. That's why we have a village to help us. I
think the other thing that it made me think is that, you know, parents don't always make these connections between how the baby like reflux or stooling and feeding. And so unless we ask them, they are not really necessarily going to give us that information. Like it's our job to recognize that might be related and ask those questions.
Yes.
And then, as you said, then request referral if needed. But I mean, a lot of these things, we don't necessarily need a referral to GI. A lot of these things can be managed by the pediatricians or pediatric healthcare providers. And that's just a matter of like them having the knowledge of how to manage those things, which is obviously really variable too. But, you know, I mean, not everywhere has a GI referral available,
Correct.
You know, by. And so, you know, those really are things that can be, a lot of those things can be managed by the pediatricians, of whether it's changing the formula or, you know, or like talking to a lactation consultant about, you know, removing things from mom's diet if she's breastfeeding or providing breast milk. You know, things like reflux meds, thickening for the purpose of reflux. Like all of those things can be done by pediatricians. It doesn't need necessarily a GI referral unless there's a suspicion that there's something like really more significant going on. Yeah.
So on the continuum of lactation counseling, you have the big bad mama jamma, the IBCLC. I have the little sister, the CLC, but I would never want to work in a NICU. My heart, I couldn't do it. So grateful for those that do. That is just, I'm too much of a Pisces and will own that. But that being said, I have found it, I don't feel comfortable because I am only a CLC to say, take this out of a diet. That's where I will reach out and talk with the doctor because I don't do it that often.
Yeah.
And that's okay. Again, I am not a silo practitioner. I pull with the team. So when you're giving the recommendation, take out dairy or take out, what does that actually look like? What can the mom not eat?
Yeah, so I would say that is actually really important to talk about because there's a lot of misunderstandings out there about, like for example, like eggs are not dairy.
Wait, that makes perfect sense to me, but the fact that one is misunderstood doesn't make sense. But okay, yes, eggs are not dairy.
Eggs are not dairy. Eggs come from chickens, not cows. We're talking about cows, milk, dairy. Also, mayonnaise is not dairy. Mayonnaise is eggs and oil. It looks like dairy, but it's not. So you can still eat mayonnaise. We're talking about...
No, I have a Duke's gallon size mayonnaise. Like I literally get Duke's mayonnaise from Costco because that is like life for Pack Dawson. So it's funny that you had to clarify that, but yeah.
Yeah. So we're talking about like milk, cheese, butter, unfortunately, cream, you know, and then paying attention to product like labeling about looking for. So milk is one of the things that is labeled as an allergen. And so for things that you're buying that are packaged, you can look at the ingredient label and the allergen statement for that. It's a little bit tricky. And I'd say where it's hardest is like going out to eat, or like buying, if you go to a bakery, those kinds of things are really, I would say, where it's hardest to manage those things. And you just have to kind of ask and then do your best.
What about whey protein?
So whey protein is based on cow's milk.
Okay.
So that's the sort of whey from cow's milk. So I would avoid that.
Folks,
I mean,
it's WHEY, just so you know. Yes.
The awesome thing is that there are a lot of non-dairy options available now.
Yes.
15, 20 years ago, that was not the case, but now there are lots of non-dairy options. So yeah, does that kind of answer the question about that?
Yes, because I have a new little one on my caseload, congenital heart defect, genetic condition, some variables. No signs or symptoms at this time for milk protein, but we are fresh spanking new home. So I'm just watching to see what goes on. But gaining weight, a couple of ounces.
That's awesome.
And that's what you want. So that's peaceful.
Yeah.
Yeah.
That's awesome.
Yeah. So one mommy to another mommy, when you're coaching these caregivers through it, because at the end of the day, we are only as good as we build those caregivers up. And I always refer people back to the Maslow scale of hierarchical need. So when we're asking them to learn and to be receptive of the knowledge that we're sharing with them, it means they have to be up in that top tier of that triangle to process the information that we have going on. When a lot of our families could still be struggling down here at the bottom because they might have a loss of income now that one of the caregivers is home with an infant. Basic needs like power, water, being able to pay your rent or your mortgage. So those factors influence a caregiver's ability to follow through with our recommendations, to pursue additional testing if there's a copay, to change diets if they have to eliminate foods, to purchase new bottles. So folks, remember when we're doing our assessments, we have to, I don't want to say get in their heads, but seek to understand where they are. Do you have recommendations on how to make a safe space for that, or how you seek to understand that? That's a really personal, hard question, but that's something that's,
It is. I mean, it's so important though.
Yeah.
I think when families come to us and they're scared and they're worried.
Yes.
What the most important thing that they want from us is to know that somebody cares.
Yes.
And that we will help, even if we are not the person that can fix their problem, that we will help them find those people. So even if you're not the one that can fix the reflux, and of course there's limitations to what you can do too, but I was just having this, I just thought about this the other day, because I was I had a mom call and she was beside herself, and the most important thing that I could do during that phone call was say, I'm so sorry that you're going through this. I would love to be able to help you. Let's, and I care that this is really hard for you, and I care about you, and I care about your baby, and I'm here to help us figure out how to make this situation better. Yeah. And if I'm not the person that can do that, I will help you figure out who that person is, right?
Be a connector.
Yeah, absolutely. and I think part of that is like, and I know this is really hard because there's a lot happening in our world right now, and it's hard to sometimes be fully present. Yep. I do think it is an act of resistance to continue to care about other people and to be present in those moments with somebody who is struggling. We can't fix everything, right? But like in that moment when I'm in this room with my patients, like I can be here as much as I'm able to be, like mentally. Yeah. And I think that's sometimes that's all that we can do. But that's really important.
Yeah. Give hope.
Yeah.
That's, I truly think that our professions are healing, right?
Yeah.
Like how awesome is it? And like the holy sense of the world. And folks, I've said this before, my Jesus loves everybody. But how awesome is it that we get to be part of their journey and to walk with them, right? And that means you're going to sit in the valley. You're going to sit in the low with them. And that's okay. So buckle up, Buttercup, because you're going to have to be comfortable in the uncomfortable but take on the ownership of knowing your community. And that's been my theme for 2 years. My theme has been community. Like people pick a word of the year, but like my theme has been community building. Like let's find your community and like let's build it and make it stronger. So when I was at ASHA a few years ago, Julia Ochura at Boston Children's, she was on stage presenting and she talked about an organization called findhelp.org. And I'd never heard of this entity before. And you type it in and then you type in your zip code and things you don't even know exist pop up. And they're like nonprofit organizations that could help pay bills, nonprofit organizations that could help get food there. Really came in clutch when WIC and SNAP was under attack, and now SNAP has been restored. I know that's not fully funded in all states or commonwealths, and I am aware of that, but like that's a resource, an additional resource in addition to the ones we listed earlier, like Dysphagia Outreach Project and different bottle organizations getting bottles to you. But that's huge, but also mental health organizations. And so many of our caregivers are working through their child's feeding concerns while also battling their own postpartum depression, anxiety, or psychosis. And that in and of itself needs to be honored and supported. And so findhelp.org can help connect with like mental health providers as well.
Awesome.
Have you heard of Tiffany Elliott from out Pacific Northwest?
I don't think so. What?
She, I'm going to find her in 2 Shakes of a Lamb's Tail. Okay, so folks, Tiffany Elliott, SLP, IBCLC, CNT, NT, MTC. Tiffany, I love you. That's a lot of acronyms, and I don't know all of them. She created something called the Hospital to Home System Change. And it focuses on NICU to early intervention for the Pacific Northwest and Washington. And that has a focus on mental health supports, but she does trainings virtually and is a great resource. And there's even training specific for caregivers and they're virtual. So that could be, she's also the most quiet, there's people that have power in their presence and they're just this quiet little fountain of joy. Yeah, that's her.
I thought of something when you were saying all of that. I do think as healthcare professionals, I think it is important to recognize that there are times when we are not able to kind of make the difference, right? Like for that family that is struggling with housing and you're making recommendations about how to make feeding better. Or, I mean, I've just had families that just aren't in that mental place to make the changes that we're talking about. And I think it's taken me a while to get to a point where I don't internalize that as a failure on my part.
Yes.
Right?
Yes.
It's that like there are limitations to what I can do. And that, you know, because I think it's also important that we like protect our
heart, our muchness.
Right? Because in order to keep doing this and keep helping families, like we can't always take all of that on ourselves.
Yeah.
And right. And so I just, especially for like new people in this world, you know, I think you're going to have cases where like you just can't make the difference that you want to make. And that's not a reflection of you sometimes. And I think it's important sometimes to just be able to say like, I did the best that I could there. And, you know, those people, they might come back to you and when they're in a place when they can make change, you know? So
yes.
I just wanted to add that.
I felt that way the first time I had a patient get a feeding tube.
Yeah.
The first time that happened, I was like, I have failed. Yeah. And I went back and looked at every single note because, you know, acknowledged my patterns. And was like, there was nothing that could have changed. And the pediatrician at the time made the comment, she was like, this is physiologic. This has nothing to do with here, physiologic. It has to do with here.
Yeah.
And that changed how I viewed a feeding tube because it was quantity over quality. And I had to wrap my brain around quality over quantity, which is to tie this back into the beginning of the conversation. It used to be make, like you said, a faster flow rate on a bottle nipple because we're looking at the numbers because they're in the feeder grower to get them out of the NICU, to get them to home health. And then we're in EI and we're like, what is happening? This is right. And now we've come full circle to recognizing it's a quality feed over quantity. Yeah. And for some of our little bitties and not so little bitties, fed is fed is fed, whether it be orally, nasally through an NG, NJ, and D, or if we need both. Like we have some kids that can feed orally during the day, but they need supplemental nourishment through a feeding tube at night, which that's a conversation for like a whole nother thing.
Yeah.
But it's okay. And we have to get to a point where we can recognize that.
And that's, I mean, I think in order for us to talk about tubes in a way that makes it feel okay for families,
yes.
like we have to definitely be there.
Yes.
So that we're talking about the tube as a way to support this baby while we continue to work on these other things, right?
Yeah, the helper. Yay, Mr. Rogers.
Yeah. Because, I mean, that often feels like a failure for the families, too. That, like, you know, yeah, absolutely.
I have so enjoyed our time together.
Me too.
This was, how blessed are my stars that I get to meet other helpers. So thank you. And I'm only going to cry a little because this was just lovely, but thank you. Okay. So love money. End of every episode, I love to ask what organization, entity, scholarship, it could be anything from spay and neutering your pets, like Bob Barker used to say, because my grandma loved him. He was dapper, to be fair, or anything else. How can we spread the love?
I love that question. The place that comes to mind is Feeding Matters.
Yes. we love on them big. Yes.
Okay, good.
Yes. We do so many guests. Well, I mean, First Bite's primarily feeding, but everything else that my little ADHD brain squirrels to. So, yes. If somebody wants to learn more from you, how do they find out about you? Courses, publications, where do they go?
Yeah, so I have two websites. Infantfeedingcare.com is where I usually post most of my publications. So pretty much like any of my papers that you want, you can fill out a little form and get there. And that's also where I generally like post courses and other presentations that I'm giving and things like that. And then infantfeedinglabs.com is where the flow rate information is. And I have like the papers that are relevant to that are on that website as well.
Beautiful. Well, thank you. Folks, thank you so much for joining us. Make sure you check us out on, I say us because I know all of the people behind the scenes that make this look good. Check us out on First Bite podcast on Instagram, Facebook. You can find me on LinkedIn. And thank you for joining us. And Dr. Pados, thank you so much for coming on.
Thank you for having me. This has been great.
Remember to visit speechtherapypd.com to earn 0.1 ASHA CEUs for this episode and to see our library of over 1,400 courses for all things SLP.